Yes, what is the topic for today? If it is asked for primary immunodeficiency, yesterday itself we have covered severe acute malnutrition and some of the questions on marasmus, kwashiorkor, etc. The left out topic today is water soluble vitamins as well as your primary immunodeficiency. Primary immunodeficiency can be an essay or it can be an your essay or it can be your short notes, but it is very difficult to cover in short notes. So most probably if it is asked with respect to primary immunodeficiency, definitely the question will be based on essay type rather than short notes, right? Okay. What do you mean by primary immunodeficiency? What do you mean by primary immunodeficiency? Severe acute malnutrition was yesterday we have covered the topic. So today let's cover about PID. So whenever any child is brought with a recurrent infection, we will always rule out HIV as the cause. Any child, we will rule out HIV. But after ruling out HIV, which is the secondary immunodeficiency rather than primary. Okay. So what do you mean by recurrent infection or recurrent multi-system infection? So look here, whenever you have a recurrent infection, you need to follow something called Jeffrey Model Foundation criteria. They will ask you this question: what is called a Jeffrey Model Foundation criteria? What is this Jeffrey Model Foundation criteria? The answer is very simple. The answer is very simple. To screen inborn errors of immunity are otherwise known as primary immunodeficiency. Inborn errors of immunity are primary immunodeficiency. Right. What are all when you need to screen a child for inborn errors of immunity or primary immunodeficiency? When four or more otitis media per year. Second, when two or more pneumonia requiring admission. Three, when you have two or more sinusitis requiring IV antibiotics. When two or more, okay, cellulitis or deep seated abscess. And then when you have organ abscess, remember it is unlikely to get deep seated abscess. I repeat, unlikely to get deep seated abscess in cases of in a normal immunocompetent child. Only immunocompromised child do have this kind of organ abscess. Organ abscess, right? Then, what are all the other questions you need to ask? Failure to unexplained failure to thrive. Okay, family history of sibling death. History of sibling death. And then persistent oral candidiasis. Oral candidiasis. Ninth one is what else? So these are all the infection, persistent oral candidiasis, unexplained failure to thrive. Okay, no, okay. Admission requiring antibiotics. Admission requiring antibiotics. Whenever you give IV antibiotic to clear infection, it comes under. And then more than 2 months of antibiotic without without any effect. So this is called Jeffrey Model Foundation criteria. So this is definitely a short notes for you. This is definitely a short notes for you. Remember, when you have two or more among this 10 points, you need to rule out primary immunodeficiency. So second point, primary immunodeficiency. Then, so this is the first point. Then comes the second one. Then they will ask you why it is called inborn errors of immunity rather than primary immunodeficiency. Remember, your immune cells not only functions against infection. You people think that it fights against infection only. Not only infection, but also cancer surveillance, but also reduces autoimmunity, but also reduces autoimmunity. So when you have defect in immune system, you will have enhanced infection, increased incidence of cancers, as well as increased incidence of autoimmune disorders. That's why primary immunodeficiency is now called as inborn errors of immunity. IEI, inborn errors of immunity. Right? So what are all the cells of immune cells? So, but remember the first investigation in any in the first investigation in any recurrent infection, is always to rule out HIV, is always to rule out HIV. Do not proceed to PID workup. Do not proceed to PID workup without doing HIV. Okay. The first investigation of choice in recurrent infection is usually HIV, unless otherwise proved, is usually HIV. Then you need, if HIV is negative, do primary immunodeficiency workup. Primary immunodeficiency workup. Right? So, second point, deficiency workup. Then, what are all the cells, what are all the disorders you have? There are so many classification, but a simple basic classification is disorders of phagocytes, disorders of phagocytes, disorders of T cells, disorders of T cells, and disorders of complement, and disorders of both T cell and B cell. Disorders of both T cell and B cell. So these are all there are so many numerous classification while we are doing any genetic workup, because each and every year, each and every day, new and new genetics has been added. As a result of which there are so many new classification. But for a fourth year graduate, when someone is asking about what are all the basic classification of inborn errors of immunity, means disorders of phagocytes, B cells, T cells, combined T cell and B cell, as well as complement. This is what you need to write. Now, so what are all the disorders of phagocytes? Disorders of phagocytes. So what are all the disorders of phagocytes? Phagocytes are otherwise neutrophils. First point, what is the onset of any neutrophil dysfunction? From birth you can have. From birth you can have. Second point, what is the organ that is involved? Usually, whenever neutrophils are affected, you are prone to Staph aureus, as well as you are prone to aspergillus. One is Staph aureus, another is aspergillus. These are all the two. So what are all this is organ affected. So what are all the symptoms? You can have recurrent skin and soft tissue infection, deep seated skin and soft tissue infection. You can have recurrent pneumonia. You can have recurrent osteomyelitis. You can have recurrent septic arthritis. These are all the, and then you can have recurrent lymphadenopathy. That's all. Recurrent lymphadenopathy. Then they will ask you one more question. Phagocytic disorder itself is a short notes. So how to write? Whenever, how do you know that the child is suffering from phagocytic infection? Whenever any child is brought with a deep seated abscess, always think in terms of uh, neutrophilic dysfunction, because neutrophils are the one which is against Staphylococcus aureus. Right. So, what are all the disorders of phagocytes? Now you speak about the classification. Disorder. Can anyone tell me what are all the three steps of phagocytosis? First one is adhesion. Adhesion. That is, the phagocyte has to be attached to the endothelium. So, and it is mediated through CD11A as well as CD18 and CD15. What are all these things? These are all cluster differentiation cells. These CD11, 18, 15 are present in the neutrophil, and they help in the adhesion and rolling against the endothelium. So whenever you have absent CD11 bar 18 or absent CD15, your leukocytes cannot adhere to the endothelium. So what will happen? You have leukocyte adhesion defect, otherwise called as LAD. Otherwise called as LAD. So what is the manifestation of this leukocyte adhesion defect? You have umbilical site abscess. You have umbilical site abscess, and you have delayed fall of umbilical cord. You have delayed fall of umbilical cord. And since infection is there, there will be a constant stimulation for the phagocytes. But these phagocytes, because they cannot adhere to the endothelium, they cannot go and reach the site of infection. They do not go and reach the site of infection. So what will happen? You have extreme neutrophilia. You must be thinking that the neutrophils are very high because the bone marrow is sending immature neutrophils to fight against all those infection, but it is not so. The increased neutrophil is mainly due to the fact that the leukocyte cannot adhere to the endothelium. This is called leukocyte adhesion defect. So what is the investigation of choice? Flow cytometry. What you will see in flow cytometry? In flow cytometry, you have reduced CD11 bar 18 in LAD1 and reduced CD15 in LAD2, leukocyte adhesion defect. Okay, what is the treatment of choice? The treatment of choice is stem cell transplant. Otherwise, the child will die. So this is one MCQ. This is one very important short notes. Which one? Leukocyte adhesion defect, otherwise known as LAD. The second short notes can be. So what is that? The second short notes. What is the first disorder of phagocytosis is adhesion. What is the second point? After it goes out of the endothelium, it will engulf the phagocyte. The phagocyte will engulf the microbe. For that, you need to have a protein called LYST, LYST. So if there is no such protein, what will happen? Phagolysosome cannot occur. So absence of this phagolysosome is called as Chidiac-Higashi syndrome. So again, Chidiac-Higashi syndrome is a short notes for you. What is that? Chidiac-Higashi syndrome. So what is this Chidiac-Higashi syndrome? Point number one, absent. What is that protein? I told you, LYST, LYST protein. So what is the function of this LYST protein? The function of this LYST protein is phagolysosome formation. Phagolysosome formation. So when you have reduced LYST, you will have defective lysosome formation. So what will happen? Again, recurrent infection. Apart from that, two more clues you granules in neutrophils. The second point is, one is giant granules in neutrophils. The second one is they will have albinism. That is, you have leukoderma, or otherwise known as vitiligo. So remember, whenever you have albinism along with recurrent. Albinism means depigmentation. Albinism means depigmentation. So whenever you have recurrent infection along with the albinism, it is Chediak-Higashi syndrome. So what is the treatment? You can give a high dose vitamin C. Again, this child requires stem cell transplant. So the second short notes is over. Chediak-Higashi syndrome. Chediak-Higashi syndrome is also comes under disorders of phagocyte. What is the third short notes? The third short notes is okay. The third point is disorders of phagocyte, disorders of NADPH oxidative burst. NADPH oxidative burst. So what is this NADPH oxidative burst? Very simple. The first point is leukocyte addition. The second point is phagolysosome formation. The third point is oxidative burst. So whenever you have reduced NADPH, your oxidative burst will be low. Oxidative burst will be low. As a result of which, there will be reduced hypochlorous acid. There will be reduced superoxide ion. There will be reduced superoxide ion. Okay, so your catalase positive organisms cannot be killed. This is very important key point while you are writing chronic granulomatous disease. What is this disease called as? This is called chronic granulomatous disease. What are all the catalase positive organisms? They will ask you Nocardia, Aspergillus, and then Pseudomonas, Burkholderia. These are all the organisms, and then Candida. These are all the organisms that produces catalase. So catalase positive organisms are prone to cause recurrent infection. So you have screening test. What is the screening test? The screening test is NBT test. So reduced NADPH oxidase leading to reduced discoloration of nitro blue dye. Okay, normally nitro blue dye is yellow in color. When it is mixed with the neutrophils, the NADPH oxidase present in the neutrophils will be converting that yellow dye to blue dye. So if there is no NADPH oxidase, that yellow color will not be converted into blue. So the number of blue colored neutrophils will be very less. So in a 100 field, if you get less than 5% neutrophils shows blue color, then it means that you are dealing with a case of chronic granulomatous disease. What is the confirmatory test? What is the confirmatory test? So the confirmatory test, the same test we will do with the help of a fluorescent dye. That is called dihydrorhodamine test. Dihydrorhodamine test. This is the confirmatory test. So what are all the questions you can be asked? One is leukocyte addition defect. Short notes, Chediak-Higashi is a short notes. Chronic granulomatous disease is a short note. So these are all the disorders of phagocyte. Now disorders of B cells. Second one is disorder of B cells. So what is the disorders of B cell? The B cells produce immunoglobulin G, immunoglobulin A, immunoglobulin M. So whenever you have low immunoglobulins, what will happen? You can have cynopulmonary infections, recurrent cynopulmonary infections. What do you mean by recurrent cynopulmonary infections? One, you have recurrent otitis media. Two, you have recurrent sinusitis. 3, you have recurrent pneumonia. As we discussed already, when you have a deep-seated abscess, phagocytic disorder. Whereas when you have a recurrent pneumonia, you need to do B cell assay. You need to suspect an underlying B cell disorder. Okay, with respect, okay, right. Apart from that, you can have recurrent giardiasis, and then you can have vaccine induced polio. Vaccine induced polio. Polio. So you all know that oral polio vaccine is a live vaccine. So when you give oral polio vaccine, there are very high chances for this oral polio vaccine itself can produce poliomyelitis in children with underlying immunoglobulin deficiency. Okay. Now, so whenever any child comes with recurrent pneumonia, recurrent otitis media, recurrent sinusitis, you need to do what test? You need to do immunoglobulin assay. You need to do immunoglobulin assay. So when you find low IgG-AM, you are dealing with a case of hypogammaglobulinemia. You all know that these immunoglobulins are produced in bone marrow by B cells. So the next point is you need to measure the number of B cells. So what is the marker or CD differentiation of B cells? As you have read in your pathology book, it is CD19. What CD19? And you all know that can be measured with the flow cytometry. So when immunoglobulins are low, do a flow cytometry. Do a flow cytometry. When CD19 is low, it means it is Bruton's A gamma globulinemia. Bruton's A gamma globulinemia. Whereas when CD19 is normal, so when CD19 is low, immunoglobulin will be low because this is a quantitative defect of B cells. Quantitative defect of B cells. No B cells, no immunoglobulin, Bruton same. But when you have a normal CD19 cells, so that in flow cytometry CD19 cells are normal but immunoglobulins are low. That means, is this quantitative defect? No, this is qualitative defect. This is qualitative defect. So this qualitative defect of B cell is called as common variable immunodeficiency. Is called as common variable immunodeficiency. Okay, common variable deficiency. The treatment for both this B cell defect is monthly IVIG replacement. Monthly IVIG replacement. Okay, that's all for both common variable immunodeficiency and Bruton's A gamma globulinemia. So B cell disorder we had completed. So we had completed disorders of phagocyte and disorders of B cells. Now let's go and see disorders of T cells. Disorders of that is also a separate question. Disorders of T cells. So now we are going to look into disorders of T cells. Order of T cells. So what is the first disorder in this? The first disorder in this is Discharge syndrome. Discharge syndrome. Now you can ask me, sir, disorders of phagocytosis are associated with the deep-seated abscess. So whenever I see any case of deep-seated abscess, I will look into phagocytic disorders. Whenever you have recurrent pneumonia, you will do immunoglobulin profile thinking in terms of B cell defect. So what should I do for T cell defect? So T cell is always characterized by persistent pneumonia. It is not recurrent. T cell defect is very severe. Persistent diarrhea. Usual onset of age is 2 to 4 months. Majority of them, because of the severe defect, the child will have failure to thrive. And remember, it is characterized by oral candidiasis. And pneumonia can be due to pneumocystis carinii pneumonia, or it can be cytomegalovirus, or it can be due to BCG vaccine that you are given by you, because BCG is a live vaccine. Or it can cause diarrhea. Diarrhea can be due to cytomegalovirus, Isospora belli, or Cryptosporidium parvum. Cryptosporidium parvum. So persistent pneumonia, persistent diarrhea, failure to thrive, oral candidiasis are manifestations of T cell defect. The first is Dijar syndrome. So what happens in Dijar syndrome? So absent third pharyngeal pouch. Third pouch, pharyngeal pouch. Third pharyngeal pouch produces thymus. So reduced thymus. So reduced maturation of T cells. And then absent fourth pouch. Absent fourth pouch. Here there is parathyroid hormone will be low. So you will have hypocalcemia. You will have hypocalcemia. So one is T cell defect, second is hypocalcemia. Apart from that, they will have congenital heart disease such as tetralogy of Fallot, or they have what velocardial cleft palate, that is called velocardial. Velo means palate. Velocardial, the other name for Dijar syndrome is velocardial facial defect. Velocardial syndrome. Velo means palate. Cardiac means tough. And then abnormal faces. So Dijar syndrome is usually characterized by 5 points. One is T cell defect, second one is hypocalcemia, third one is tetralogy of Fallot, fourth one is cleft palate, fifth one is, what is that? Abnormal faces. So this triad is called as Dijar syndrome, otherwise known as catch 22 deletion Q, because this absence of third and fourth pharyngeal pouch arises as a result of deletion of long arm of chromosome in long arm of chromosome, right? Catch 22 to 11th band of long arm of chromosome 22. So whenever you want to find out these deletion, what is the investigation of choice? The investigation of choice is FISH, fluorescent in situ hybridization technique, to find out are these micro deletion. So Dijar syndrome, what are all the 5 points? It is due to deletion of long arm of chromosome band 11. Second point is third and fourth pharyngeal pouch is gone, and then characterized by 5 points. T cell defect leading to infection, parathyroid defect leading to hypocalcemia, tetralogy of Fallot, velocardiofacial syndrome, and then abnormal faces or dysmorphic faces. The treatment of choice here is IVIG replacement, but long-term management is bone marrow transplant. Along with that, you need to give calcium and vitamin D. Lifelong, because of absence of parathyroid gland. So this is the first defect. Then they will be asking you what is called MSMD. What is MSMD? Mendelian susceptibility to mycobacterial diseases. What? Mendelian susceptibility to mycobacterial diseases. You need to know that Th1, okay, is converted from T0. What is T0? T0 is a pluripotent stem cells in which if interleukin 12 acted on, Th1 will be converted, T0 will be converted to Th1. This Th1 will secrete interferon gamma. This interferon gamma in turn attract macrophages. This macrophages kills kills macrophages produces tumor necrosis factor alpha, which in turn kills intracellular organism. What are all the intracellular organisms? One is TB, second one is typhoid. These are all the predominant intracellular organisms. So in Mendelian susceptibility to mycobacterial disease, there is a defect in TH1 or interleukin 12 or interferon gamma. So you will get a recurrent TB. You will get recurrent typhoid, recurrent TB or recurrent typhoid. This is called Mendelian susceptibility to mycobacterial diseases. Again, the drug of choice is bone marrow transplant. So this is another T cell defect. So the first T cell defect is Diger syndrome. The second T cell defect is MSMD. What is the third T cell defect? That is called hyper IgE syndrome. What is that? That is called hyper IgE syndrome. So what is this hyper IgE syndrome? So now you need to know the third important is hyper IgE syndrome. So like your Diger syndrome, this is characterized by a mnemonic called FATET. So what is called F? F stands for abnormal phases. Stands for abnormal phases. A stands for abscess, which is painless abscess, small abscess. This small painless abscess is called as Job syndrome. This is called Job syndrome. T stands for retained primary teeth. Usually, temporary teeth should fall and the primary, secondary permanent teeth should occur. But here, temporary teeth will be there and primary teeth will appear. This is called retained primary teeth. And what we call it as a double row of teeth. Double row of teeth. E stands for elevated IgE and E stands for elevated absolute eosinophil count. And D stands for eczematous dermatitis. So you have two things, autosomal dominant and autosomal recessive. Autosomal dominant is due to STAT mutation, whereas autosomal recessive is due to DOCK8 mutation. Okay, which one? Hyper IgE syndrome. Okay, so whenever any child is brought with a recurrent deep-seated abscess, painless superficial pustules along with the severe eczema, you need to think in terms of hyper IgE syndrome, right? And finally, what is the last T cell disorder? The last T cell disorder is chronic mucocutaneous candidiasis. Chronic mucocutaneous candidiasis. So this is characterized by reduced TH17 defect. TH17 is the one which is responsible to attract neutrophils. So new neutrophils will come, as a result of which you will get chronic candidiasis involving tips of mucocutaneous candidiasis involving oral cavity, palms and soles as well as head. So the manifestations of T cell disorder are: one is Diger syndrome, hyper IgE syndrome, Mendelian susceptibility to mycobacterial diseases, and chronic mucocutaneous candidiasis. Candidiasis. Okay, right. So this one is over. Phagocytic over, T cell over, B cell over. Just in 40 minutes we are completing the entire topic. Now combined T cell and B cell. Combined T cell and B cell. So what are all the combined T cell and B cell disorder? One is severe combined immunodeficiency. Second one is Viscott-Aldrich syndrome. Third one is hyper IgM syndrome. Fourth one is ataxia telangiectasia. Five points we will cover. So 5 point we will skid means reduced T cell. The marker for T cell is CD3, so it will be reduced. Reduced NK cell, the marker for NK is CD, okay, 56. It will be reduced. The marker for B cell, as we discussed already, reduced CD19. Reduced CD19. So what is the manifestation of SCID? As I told you already, this is a severe form due to interleukin 7 defect. There are some other mutations also. So what will happen? Persistent pneumonia, persistent diarrhea due to that PCP, BCG. What I told you in Mendelian susceptibility to mycobacterial illness comes under here also. So what is the clue? The clue is reduced absolute lymphocyte count. Reduced absolute lymphocyte count. In children less than 1 year, ALC should be more than 1000, 3000. Okay, when A absolute lymphocyte count is less than 3000, when absolute lymphocyte count is less than 3000 in an infant with a persistent pneumonia, suspect severe combined. And another clue is absent thymus in X-ray. Thymus in X-ray. Okay, treatment is immediate stem cell transplant. So almost severe combined immunodeficiency, you can raise these 10 points. Then you can ask me, sir, what is the marker for B cell deficiency? So the marker for B cell deficiency, where it is, marker for B cell, where I had written. Okay, the marker for B cell disease is absent tonsil, not thymus, absent tonsil. Okay, then you have Viscott-Aldrich syndrome. Viscott-Aldrich syndrome is characterized by a triad of eczema, recurrent infection, and then microthrombocytopenia. Microthrombocytopenia. That means mean platelet volume will be less than 6 femtoliter. Normally it is 10. And then platelet will be less than 1.5 lakhs. Here what is the defect? The defect is reduced actin, so no movement. Reduced actin, so no movement. It comes under combined defect. Which one? Viscott-Aldrich syndrome. Remember, it is X-linked, like Bruton's A gamma globulinemia, like severe combined immunodeficiency, one variant. And then ataxia telangiectasia. What is this? Ataxia telangiectasia, AT. It is characterized by triad of ataxia. So ataxia usually comes around 5 years. You have telangiectic blood vessels, and then reduced IgA and increased alpha fetoprotein. So this is all about ataxia telangiectasia. Okay, it is a DNA repair defect. Finally, we have come up with IgM. So what is, okay, finally we have come up with IgM. Sir, what is hyper IgM syndrome? Another MCQ. So look at this. This is T cell. This is B cell. B cell produces usually IgM, but The CD40 ligand of T cell combined with CD40 of B cells. CD40 ligand of T cell combined with the CD40 of B cell means you will get isotype switching. What is called isotype switching? IgM producing B cells will produce other immunoglobulins like GAE. This is called isotype switching. So in hyper IgM syndrome, there is reduced CD40 ligand. So reduced isotype switching. So what will happen? All immunoglobulins will be low, like IgGAE will be low, but here even without the help of T cells, your B cells will produce IgM. So what will happen? IgM can be normal or even can normal or be high. Which one? Hyper IgE syndrome. Most common infection is PCP, primary cystic carinae. And here also you need to give IVIG and you need to do a stem cell transplant. You need to do a stem cell transplant, right? Which one? This one is hyper IgM. So what are all the hyper IgM syndrome? The hyper IgM syndromes are, sorry, what are all the combined defect? Severe combined immunodeficiency, viscous tolerance syndrome, ataxia, telangiectasia, and hyper IgM syndrome. These are all combined T cell and B cell disorder. Finally, complement disorder. Complement disorder. You have, when you have reduced to C3b, C3b is an opsonin. So reduced C3b means opsonin cannot help the B cell to destroy the microorganism. So you have a recurrent otitis media pneumonia sinusitis. What? Otitis media pneumonia sinusitis. When you have reduced CD5b to 9, it is otherwise called membrane attack complex. It is called CD, okay, CD5 to 9, membrane attack complex, and it inhibits Neisseria meningitis. Meningitis, a recurrent meningococcal meningitis can occur. So when you have low C1 esterase inhibitor, you will get recurrent angioedema. C3b, C5b29, recurrent C1 esterase inhibitor reduced. Okay, and then reduced early complement factor C2, C4. It reduces autoimmunity. Reduced C because C2C, whenever C2C4 is the one which binds with the unnecessary antibodies and produce wastage in urine. When C2C4 is not there, there is increased incidence of autoimmunity, and what we call it as SLE like illness, otherwise known as early onset SLE, otherwise known as early onset SLE, when it occurs less than 4 years. So these are all the manifestations of complement disorder. Complement can be treated by giving FFP, or you can give complement factor. You can give, this is called complement disorder. Remember, my dear friends, by about 47 minutes, we have entirely completed our session on immunodeficiency. So we have seen what are all the things we have seen: phagocytic disorder, disorders of B cells, disorders of T cells, combined T cell and B cell, as well as complement disorders. Now, what is the investigation of choice? What is the investigation of choice? Investigation of choice. The first choice is HIV. If positive, don't do. If positive, don't do PID workup. If negative, and in Jeffrey Model Foundation, two or more infection, you need to counsel for PID workup. To counsel for PID workup. So what is step one? Step one, CBC. Why? Because when you have reduced platelet, it means viscous aldreds. You have increased absolute neutrophil count. It can be either CGD or leukocyte addition defect. Okay, when you have increased AEC, it is a case of hyper IgE. When you have low absolute neutrophil count, it was cyclical neutropenia. This is called cyclical neutropenia. So, and then when you have reduced absolute lymphocyte count, you are in favor of a severe combined immunodeficiency. When you have absent tonsil, a short revision. Rutan. Absent thymus means T cell defect. Dysmorphism means hyper IgM. I'm sorry. Dysmorphism usually occurs in which condition? Viscott-Aldrich syndrome and then Digeard. Okay, Viscott-Aldrich syndrome and Digeard syndrome. Diagnosis part and all over. Which one? Okay. So by doing a simple CBC, you look here, you can rule out so many immunodeficiencies. Reduced ALC, I repeat again, reduced ALC, severe combined immunodeficiency. Reduced ANC, neutropenia. Increased ANC, chronic granulomatous disease. Elevated IgE, hyper IgE syndrome. Reduced platelet. What is that? Viscott-Aldrich syndrome. Reduced platelet. And then reduced immunoglobulins means B cell defect. If CD19 is low, stem cell transplant. If CD19 are high, if CD, okay, so platelet, if CD, okay, one second. Okay, so if CD19 is low means it is Bruton's lifelong A gamma globulin. CD19 is normal means it is common variable immunodeficiency. Both of them will put on monthly IVIG. Will put on monthly IVIG. So this is the basic investigations for combined severe or any immunodeficiency. Remember the first point should be HIV, and also you left out one point, granules in cytoplasm of neutrophils. Here also it is. Here also here also it is. What is that? Giant granules in neutrophil is nothing but just now we have read na Chediak-Higashi syndrome. Chediak-Higashi syndrome. So these are all the workup, and then reduced CD19 Bruton. Normal CD19 with A gamma globulinemia, common variable immunodeficiency. Reduced CD3 T cell defect. Reduced CD56, again NK cell defect. NK cell defect. Reduced NK cell defect. Okay, now you know the diagnosis. So what are all the advanced tests? What are all the advanced tests? The advanced test one is HIV, I told you, CBC, I told you, peripheral smear, I told you, So NBT and DHR are mainly from or chronic granulomatous disease, whereas reduced immunoglobulin, either CVID or Bruton, ID or Bruton. Okay, reduced CD56 NK cell defect, 16 reduced CD3 comes under T cell defect. It comes under T cell defect. So these are all the advanced investigation. Treatment: monthly IVIG when there is reduced humoral immunity, daily Septron for bacterial infections, daily Oriconazole for fungal infections, and daily acyclovir at times you will be used in hyper IgE syndrome type 2, that is autosomal recessive. Avoid all vaccines in T cell disorder. Avoid all vaccines in T cell disorder. In T cell disorder, avoid live bacterial vaccines. In live bacterial vaccines are contraindicated in chronic granulomatous. Okay, I think we have completed. Primary immunodeficiency comfortably. What? Comfortably. So 2 minutes. You just try to read this. Let me have a water and come. Just 2 minutes. Just 2 minutes. Not more than that. Be online. Be online. So these are all the. Sorry. So that's it. So this will be shared to you. So these tabular columns will be shared to you. Don't worry. So everything we had discussed, we'll have a short revision now. Once again, right. A short revision. T cell defect, as I told you, persistent pneumonia between 2 to 6 months. So cytomegalovirus, everything, TB, everything, Candida. So these things are explained. So I don't want to do it again and again, again and again. So let us see some of the common one-liners that will be asked for you. Common one-liners that will be asked for you. So Dijar syndrome, hypocalcemia, unusual phases, heart disease, tetralogy of Fallot, delayed cord fall, leukocytosis, leukocyte addition defect. Persistent oral thrush is a manifestation of severe combined immunodeficiency. Blood in stools. Eczema is manifestation of two diseases. One is hyper IgE syndrome, another is viscous tolerance syndrome. Pneumocystis gyrovasi, neutropenia, hyper IgM syndrome. Pyogenic means early complement factor deficiency, C3b deficiency. Okay, so what are all the other things? Recurrent staphylococcal abscess, nematocele, hyper IgE. Chediak-Higashi syndrome means giant granules, and then albinism. Whenever you have recurrent suppurative adenitis, you are dealing with a case of recurrent otitis, recurrent sinopulmonary infections, B cell defect, persistent pneumonia 2 to 6 months, T cell defect, eczema, hyper IgE syndrome, and hyper IgE Iscard-Aldrich syndrome, and deep-seated abscess manifestation of neutrophilic disorders such as what is that? Phagocytic disorders, right? Okay, these are all the things that we have learnt. So all things I have taught you, all these things where we have seen right now. So this is, we have written, and this is in printed format. Stat 3, doc 8, Chediak-Higashi, chronic granulomatous disease, all things I have taught to you. Okay, so now we have now I taught you about primary immunodeficiency in detail. So yesterday we have not discussed about water soluble vitamins. Yesterday we have not discussed about water soluble vitamins. So what are all the water soluble vitamins, and what are all the questions they will ask? Let me see. Remember, so what are all the most common MCQs that can be MCQs, as well as in Viva OC they will be asking you? Very simple. So remember, all are easily washed out from the body. I repeat, all water soluble vitamins are easily washed from the body except B9. Except B9. B9 cannot be washed in the body. B9 is stored in the liver for about 3 months. Is stored in the liver for about 3 months. Stored in the liver for about 3 months. The second one is B12 is stored in the liver for about 3 years. B12 stored in the liver for about 3 years. And remember, all B12 vitamins are coenzymes. All B12 vitamins are coenzymes, are precursors to enzymes. So it is mainly used in many inborn errors of metabolism also. Thiamine is B12, B1. Thiamine is B1, riboflavin is B2, niacin is B3, B5 is pantothenic acid, B6 is pyridoxine, B7 biotin, B9 folate, ascorbic acid we had discussed yesterday. Thiamine is a cofactor for thiamine pyrophosphate. Riboflavin is a cofactor for flavin mononucleotide or flavin adenonucleotide. Niacin is a cofactor of nicotinamide. And pantothenic acid is a cofactor for acetyl-CoA. And pyridoxine is a cofactor for pyridoxal phosphate. It's a cofactor for pyridoxal phosphate, right? So what are all the things that will be asked? This naming B1, B2, B3, B7, B9, everything will be asked in Viva OC. But there are some questions that will be asked with respect to inborn errors of metabolism, because many water soluble vitamins are being used as a cofactor. So I repeat once again, what are all the disorders that we use, or else what might be the short question? The short notes may be the role of water soluble vitamins B in inborn errors of metabolism. Let me write one. B1, that is thiamine. B1, thiamine. Thiamine is used in maple syrup urine disease. Okay, one. The second one is B2. Second one is B2. B2 are otherwise known as riboflavin. Riboflavin is used in mitochondrial disorders. This question will definitely will be a tough questions, but the people will be very happy when you answer this kind of tough questions. Riboflavin. Okay, B1, B2, and then Nias, and then what is B7? So B7 is nothing but nothing but biotin. B7 is, one second, B7 is nothing. So B7 is biotin. Biotin is used in multiple carboxylase deficiency. Multiple carboxylase deficiency. B7. Okay, and then you have, what is this? B6, pyridoxine. Pyridoxine. Pyridoxine is used in homocystinuria. Used in homo is used in homocystinuria. Okay, and then B6, B7. What else you have? B12. B12 is used in B12. What is B12? B12 is cobalamin. Cobalamin. It is used in methyl malonic aciduria. Is used in methyl malonic aciduria. Which one? B12 is used in methyl malonic aciduria. Okay. So what else you can have? Okay, so these are all the things, and then niacin is used in Hartnup disease. Hartnup disease, in which neutral amino acids tryptophan will not be absorbed. Niacin. So these are all the uh, vitamins that are used in inborn errors of metabolism. Definitely, this might be a short question. You will be definitely it will be asked. So please go through this one. Go through this one, right? And then with respect to other thing, remember what is the relationship between diet? What is the, this is a question that can be asked very easily in your Viva OC. Vegetarians are more prone to develop B12 deficiency, iron deficiency, as well as, what is this? What is that? B2. So vegetarian diet doesn't have riboflavin, B12, iron, as well as vitamin D. Vitamin D is mainly present in fish. Okay, apart from sunlight, it is present in fish. So vegetarians are prone for B12, iron, D, and riboflavin deficiency. Whoever eats raw egg contains avidin. Raw egg contains avidin. Avidin do not release your biotin, as a result of which it will, when you eat raw egg, biotin will not be released by the avidin, leading to biotin deficiency. And then untreated corn. When you eat more and more corn doesn't have any niacin, leading to niacin deficiency. Leading to niacin or B3 deficiency. What is that? 3D pellagra. What is that? Okay, what is that? What is the three D's? Diarrhea, dermatitis, dementia. Diarrhea, dermatitis, and dementia. Whenever you eat more corn. Whenever you eat more corn. Okay, then eat more corn. So a short revision on what is this? B1. You all know that thiamine means the active form is thiamine pyrophosphate. The active form is thiamine pyrophosphate. Okay, pyrophosphate, because it is a cofactor for branched chain keto acid dehydrogenase. And this is again a short notes that can be asked in biochemistry. Thiamine pyrophosphate can play a role in branched chain keto acid dehydrogenase, pyruvate dehydrogenase, alpha keto acid dehydrogenase, and then trans ketolase. So these are all the four enzymes used in intermediary metabolism that requires thiamine. So what is the thiamine? So what are all the things that you need to know? Thiamine is sensitive to heat and light. So what will happen when you do more and more, when you heat it, even though it is present in milk and meat, when you heat it, what will happen? It will lead to loss of thiamine in the water. And also whenever you do polished rice, the more and more you polish, the more and more thiamine that is present in the outer coat will be removed. But the recommended daily allowance is 0.5 milligram per 1000 calories. What are all the deficiencies stated? As I told you, eating polished rice and malabsorption, majority of vitamins except B12 and folate are absorbed in the duodenum and jejunum. So B12 and folate are absorbed in ileum, very very important. Okay, so whenever you have a malabsorption such as celiac disease, or eating polished rice or alcoholism which increases the metabolism of thiamine, you are prone to develop thiamine deficiency. So what are all the manifest? This is again, this single PPT is definitely a short notes for you. Not all B complex vitamins will be asked in your short notes. The major B complex vitamins that will be asked in your short notes are: one is B12, another is niacin, third one is thiamine. So the rest of the things I don't think they will be asked you, but they will be concentrating on entrance MCQs, or they will be concentrating on Viva OC. For theory exam, thiamine, niacin and B12 will definitely will be asked. And what are all the manifestations of thiamine deficiency? One is dry beriberi manifesting as polyneuropathy, congestive cardiac failure leading to wet beriberi, and infantile beriberi. What is that? Infantile beriberi. So what is this infantile beriberi? It is characterized by a tetrad of ABCD. A stands for aphonia, B stands for cardiomegaly, C stands for cyanosis, and D stands for dyspnea. So one cause for infantile aphonia is thiamine. In one cause for infantile aphonia is thiamine deficiency. Wernicke-Korsakoff's encephalopathy. You all know that alcohols are prone to develop this Wernicke-Korsakoff encephalopathy, characterized by confusion, ophthalmoplegia, nystagmus, and ataxia. What we call it as CONA. What is CONA? Confusion, ophthalmoplegia, nystagmus, and ataxia. So this is called CONA. The main organs affected here are: one is mammillary body, another is medial dorsal nucleus of thalamus. One is mammillary body, another is medial dorsal nucleus of thalamus. What is the diagnosis for thiamine deficiency? The diagnosis for thiamine deficiency is: either you can measure 24-hour urine thiamine, or you can measure RBC transketolase activity. So measurements of RBC transketolase activity is an indirect measurement of thiamine deficiency. In deficiency, you need to give 5 to 10 milligram of thiamine per day. And there is one more condition called thiamine responsive megaloblastic anemia. Right? So this is all about thiamine. I repeat again, thiamine is a 5-mark question for you. Please do not forget. Thiamine is a 5-mark question for you. Dry beriberi, wet beriberi, infantile aphonia, Wernicke's encephalopathy. Other usages, it is used in dash. What? It is used in thiamine responsive megaloblastic anemia. Okay, right. Then, so another, what are all the components of the second vitamin is riboflavin deficiency. So what are all the components? Riboflavin is mainly its role in oxidation reduction reaction. What? Oxidation reduction reaction, like your thiamine. The requirement is zero point 0.4 milligram per 1000 calories. It is present in vegetarian diet. Again, it is it is what will happen. It is insensitive to heat, light, pasteurization, and sterilization. As a result of which, deficiency status is very rare because riboflavin is insensitive to heat, light, pasteurization, and sterilization. The riboflavin deficiency, most important entrance MCQ question that will be asked is, in riboflavin deficiency, you will have circumcorneal vascularization. So, circumcorneal vascularization is a manifestation of riboflavin deficiency, angular cheilitis, beefy red tongue or glossitis, and nasolabial seborrhea. What is that? Nasolabial seborrhea. Right? Dry skin in and around the mouth is called as nasolabial seborrhea, occurs in riboflavin deficiency. If you ask me whether riboflavin deficiency will be asked in 5 mark question, no, it will be asked in Viva OC. And riboflavin deficiency, riboflavin is a cofactor for glutathione reductase. So when riboflavin is not there, glutathione reductase will be low. Like thiamine, riboflavin deficiency is treated by giving 5 to 10 milligram of riboflavin per day. Right? The third B complex vitamin is B3, or otherwise known as niacin. B3 or otherwise known as niacin. So niacin is a component of, you all know, again oxidation reduction reaction like riboflavin, and it occurs as a cofactor in the name of NAD and NADP. And the recommended daily allowance is around 8 niacin equivalent per 1000 calories. Niacin is derived from tryptophan. So 60 milligram of tryptophan is equal to 1 niacin equivalent. 1 niacin equivalent. And it is also present in maize, meat, egg. It is also present in milk, grains, meat, and egg. And it is insensitive to heat, so that you can give. The deficiency state usually occurs in maize eating population. So B3 niacin deficiency will be manifesting, as I told you already, diarrhea, dementia, dermatitis, death, and you have a rash in and around the photosensitive area in the form of castle necklace, and broad collar rash in sun exposed areas. This is taken from net. This is okay. Sun exposed areas. Okay, literally, I have not seen any case of, what is that? Niacin deficiency. So, pellagra. Pellagra is nothing but a niacin deficiency. Is nothing but a niacin deficiency. It usually occurs in 7:30. Okay. It occurs in children with a malabsorption and also in chronic alcoholics. Okay. So the daily requirement is 50 to 300 milligram per day. That is the treatment. So what is this pantothenic acid? Literally, we don't have any deficiency status of a pantothenic acid. It occurs only in experimental animals. The deficiency often leads to burning feet syndrome. What is that called as? The deficiency often leads to burning feet syndrome. Leads to burning feet syndrome. Leads to burning syndrome only in experimental animals. Only in experimental animals. Not there in humans, not being reported. Okay, then comes, okay, which one? B5. B5. No, I'm sorry, this is for B5. What for B6 or pyridoxine? B6 or, this is for B5. Which one? Burning foot syndrome. Now comes B6. Now comes B6, pyridoxine. It usually occurs as pyridoxal phosphate. 1. As I told you, it is used in homocystinuria. It is used in homocystinuria. What is the role of pyridoxine? It acts as a cofactor for cystathionine beta synthase. So what will happen in this? Cystathionine will be converted into homocysteine, which in turn will be converted into cysteine. And it is arising from methionine. So when there is no pyridoxine, what will happen? Your homocysteine levels will be high, and your methionine levels in the blood will be very high, and you will get homocystinuria. And you will get, what is the disease? Homocystinuria. The treatment of homocystinuria is pyridoxal phosphate supplementation. Another condition in which you will give pyridoxine is intrauterine seizures. What is that? Intrauterine seizures. Why? Because when you have reduced pyridoxine, what will happen to GABA? GABA will be reduced. GABA is an inhibitory neurotransmitter, so it will lead to imbalance, leading to excess excitation, leading to intractable seizures. So this is all about pyridoxine. Okay, very, very important. This is all about pyridoxine. And then comes B7, biotin. Often asked questions with respect to Viva OC is biotin. So level 1, level 2. Level 1 question is, they will ask you which food leads to biotin deficiency, means eating raw egg. Raw egg contains avidin. Avidin will not release biotin from the binding site. Second one is eating anticonvulsants such as isoniazid. What is the clinical picture of biotin? Biotin is a cofactor for multiple carboxylase. By very, very important point. Biotin is a cofactor for multiple carboxylase. So when multiple carboxylase is reduced, it is characterized by triad of alopecia, developmental delay, and then neuroregression. So neuroregression with intractable seizures. Biotin 5 to 10 milligram is sufficient. 10 milligram, very, 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 very important question with respect to biotin. And finally, what is this? B9. Finally, B9, or otherwise known as folic acid deficiency. B9 is folic acid, otherwise pteroyl monoglutamic acid. What is that? Pteroyl monoglutamic acid. The requirement of it is used mainly in folic acid is folic acid, B12, pyridoxine, or hematopoietic vitamins. I repeat, what are hematopoietic vitamins? Hematopoietic. Okay. One is folic acid, 730. One is folic acid. Second one is B12. Third one is pyridoxine. These are all hematopoietic vitamins. Folic acid, as you all know, for what are all the deficiency manifestation? Let's see. It is present in all. Is there any Important thing that has to be shared, no green leafy vegetables and sunflower seeds. Again, it is the deficiency manifestation mainly in celiac disease. Okay, hemolytic anemia giving phenytoin. Phenytoin causes folic acid deficiency. It retards the absorption of folic acid. Okay, short bowel syndrome in survivors of necrotizing enterocolitis, a condition in which preterm intestine will undergo gangrene and they need to remove it. In those conditions, they are prone for folic acid deficiency. What is the manifestation of folic acid deficiency? Again, folic acid is responsible for DNA synthesis. Folic acid is responsible for DNA synthesis. So, whenever you don't have folic acid, you will get megaloblastic anemia. What you will get? You will get megaloblastic anemia. What is called megaloblastic? And then I will say macrocytic anemia. Megaloblastic and then macrocytic anemia. Macrocytic means MCV more than 100 femtoliter. Megaloblastic means more than 6 lobes of neutrophils. More than 6 lobes of neutrophils. That is megaloblastic. So this megaloblastic macrocytic anemia occurs in folic acid deficiency. Folic acid deficiency. Megaloblastic macrocytic anemia occurs in folic acid deficiency. It can be detected by doing either RBC folate level, and also indirectly what will happen, the homocysteine will be very high. The homocysteine will be very high. Okay, in which condition? Folic acid deficiency. Treatment is giving daily folate. Treatment is giving daily folate. Remember, in all cases of megaloblastic macrocytic anemia, first give B12. First give B12, then give folate. Because B12 deficiency is more common than folate deficiency. When you don't treat B12 and giving folate leads to neurological worsening. Leads to neurological worsening. This is very, very important. This is very, very important. Neurological worsening. And finally B12. Very, 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 very important. Finally B12. B12 is nothing but cobalamin. So what is the role of B12? B12 converts methyl malonyl CoA to succinyl CoA. This reaction is very, 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 very important. Methyl malonyl CoA to succinyl CoA. So what will happen when B12 is not there? When B12 is not there, the homocysteine will not be converted into the homocysteine, okay, will be converted into methionine. So folate gets trapped in methionine. Folate gets trapped, as a result of which you will have many problems in the body. So what are all the manifest B12? B12 is predominantly found in non-vegetarian. So you need to rely on non-vegetarian diet, or you need to have excess milk. In B12 and folate deficiency, there is something called folate trap. What is that mechanism? Folate trap. Folate is usual for myelin. So what will happen? There will be poor myelin formation. What are all the manifestations of B12 deficiency? Very, very important. Very, very important. One is macrocytic megaloblastic anemia. One is macrocytic megaloblastic anemia in B12 deficiency. Second one is infantile tremor syndrome. Often asked question. Infantile tremor syndrome, B12 deficiency. Third one is homocystinuria can occur. And then methylmalonic aciduria can. And then, as in adults, because of demyelination, you will get subacute combined degeneration of spinal subacute combined degeneration of spinal cord. And remember, not only anemia, it will cause pancytopenia. All cell lines will be decreased, and there is increased incidence of stroke because of elevated homocysteine. Because of elevated homocysteine, which one? Stroke. So remember, in folate deficiency and B12 deficiency, you will have macrocytic megaloblastic anemia. But B12 means you will have neurological manifestations plus, which is absent in folate. Second point is, in B12, methylmalonic acid will be increased. In folate, MMA levels will be normal. So MCV more than 100 femtoliter, more than 6 lobes in single neutrophil is called megaloblastic, or 5 or more lobes in 5% of the neutrophil is called megaloblastic, or else you can do serum cobalamin levels in which either less than 200 picogram per ml is called as deficiency status. Deficiency status. So remember, majority of us right now are using IM B12. IM B12. Okay, B12 is given almost zero point 0.1 milligram per day, thrice weekly 2 weeks, followed by weekly 1 dose 6 weeks. Okay, 6 weeks. So this is the you at times you need to give lifelong B12 supplementation. B12 supplementation. In many neurological disorders, B12 will be attempted. B12 it will be attempted. So remember, a B12 deficiency is associated with not only macrocytic megaloblastic anemia but also infantile tremor syndrome, homocystinuria, methylmalonic aciduria, subacute combined degeneration of spinal cord, pancytopenia, increased incidence of, right? And what about, let us finish C also, even though there are some points were finished in yesterday topic. Again, C is used in oxidation reduction reaction, right? Folic acid and niacin. Requirement is 40 milligram in infants, 60 milligram in children. When you eat one single orange per day, it is more than enough. And it is spoiled by cooking, storage, but it is stable in canned foods. Humans rely completely on intestinal bacteria because the glutathione reductase that is essential for vitamin C is absent in humans. So what are all the manifestations of vitamin C deficiency? Bleeding, pseudo paralysis because of subperiosteal bleeding. Because of subperiosteal bleeding, you will have painful limbs, pseudo paralysis. Hemopericardium, hemopericardium, pericardium. So what are all the are in poor wound healing, poor wound healing. Apart from that, what are all the things you can have in vitamin C deficiency? So you have ringed epiphysis, that is called Wimberger sign. You have pits in the metaphysis, translucent zone in metaphysis, that is called tremor filled zone. There are some projections, from the bone. They are called Pilken spur. And then what will happen to cortex? They will have pencil thin cortex. They will have pencil thin. These are all the radiological features of vitamin C. Vitamin C. Micronutrients. In which condition you will get hypogonadism? In which condition you will get hypogonadism? Reduced cell mediated immunity, alopecia, acral dermatitis dysgeusia. In which condition? Yes, you are correct. So what is that condition called as? Acrodermatitis enteropathica. Acrodermatitis enteropathica due to congenital zinc absorption defect. Okay, one second one is, so this is acrodermatitis enteropathica. Next one, selenium deficiency. Selenium deficiency leads to Keshan's cardiomyopathy. Keshan's cardiomyopathy. Magnesium deficiency leads to tetany. So tetany not responding to calcium. Think magnesium deficiency. Okay. So and then iodine deficiency leads to goiter. And last but not least, copper deficiency. Okay. So copper deficiency leads to microcytic hypochromic anemia along with neutropenia. One cause for microcytic hypochromic anemia along with the neutropenia, think about copper deficiency. Copper excess leads to two diseases. One is kinky hair disease. Another is Wilson. Kinky hair disease is due to defect in ATP7A. Wilson disease is due to ATP7B defect. With this, we are completing our topic for today. Thanks for your patient listening. We will meet on 24, 25 and 26 to finish all other topics that are left. Thank you. In case if you want any other questions that has to be discussed, either essay or short notes, you can ping PW or you can ping this